Good morning, ladies and gentlemen. Welcome back to the second day of SIMCON 2025. We begin with how to pass MD, communication and observe history taking. This session continues our commitment to supporting postgraduate trainees through practical, experience-based guidance on MD examination success. To begin today's program, I warmly invite Dr. Rakita Higoda to moderate the session.
Good morning. Now we have come to the third and the last segment of How to Pass MD series of SIMCON, which is the communication and observed history taking station. We'll be starting with the communication station, and today our resource person and the examiner will be Professor Shamila De Silva, Professor in Medicine, Faculty of Medicine, University of Kelaniya. And Dr. Muru Veeraratne, Medical Registrar from National Hospital Galle, has kindly agreed to volunteer with the session. And Ms. Nilakshi will be playing the role of the surrogate. I kindly invite all to the stage to start the session. And in the interest of time, we have given the case scenario of 5 minutes prior to the session to the candidate so that we can save time on the actual discussion.
Good morning, everybody. So we will get started. This is our instructions to the candidate. And if you can have the bell, we'll get started now.
Good morning. I'm Dr. Muru from the medical ward. And may I know your good name, please?
Good morning, doctor. I'm Kanti Pera.
Great. Miss Kanti, can I know how old you are?
48 years.
Great. So, Miss Kanti, I've come to talk to you about, certain investigations we've done on you in your current ward stay. And I believe this is an adequately private location for us to talk.
Yes, doctor.
Yeah. And you're comfortable with the language, is it?
Yes, doctor.
Great. So, Ms. Kanti, I've referred your notes, and my colleagues have informed me that you've admitted this time with some high blood pressure,
Yes,
right?
doctor.
And I've gone through your past notes. But just to get things straight from the start, may I know what you've been told so far regarding your disease? What is your knowledge on your disease?
Thing is, doctor, so I was first diagnosed with blood pressure about 12 days ago, and I had a heart attack 3 years ago also. So, recently we had a insurance for a work review, and there was medical to be done. And at the medical, I was told I'm having high blood pressure and to get admitted immediately. So that's the reason I had to come to hospital. But now it seems under control, so yeah.
Yes, now I've referred your notes today, and it is indeed under control. So that's good news.
Yes.
Of course. Ms. Kanti, are you employed, occupied?
I am, yes.
And in what?
I'm an assistant manager at a supermarket.
Great. Okay. So, Ms. Kanti, actually, you've been having high blood pressure, and you got some heart attack as well previously,
Yes,
right?
yes.
And you are just still of 48 years of age,
Yeah.
right? And quite fit. So, I've come here to speak now. Currently, we are controlling your blood pressure on very high doses of medicine that we are using for your blood pressure, right?
Okay.
So, it's controlled at the moment, but we've done some other investigations while your ward stay. And it has shown some problem in your kidneys. Your kidney function is a bit elevated. It's a bit. And we've also found that you're passing some protein in your urine from the tests we've done.
Okay.
Has it been, have you checked your kidney function before? Or
Not
urine?
recently, no.
Not
doctor,
really,
no.
right? Okay. So, so there may be some side effects or, bad effects of your blood pressure. And also, this time we've done an echo, a scan on your heart, and that has shown that there's a bit of, some changes due to high blood pressure over time. Sometimes our heart can get a bit weak, and there are some changes that we can see on the ECG and the echo. So we believe those are all due to poorly controlled blood pressure over the time. So may I know, so where are you on follow-up for your clinic, for your blood pressure?
Sorry? I didn't get
Where are you on follow-up for your high blood
no,
pressure?
I was given some medicines, but I was feeling quite fine. I was feeling normal. I was doing my day-to-day work. So I thought it was not necessary for me to take the medicine because there was no symptoms of any high blood pressure or anything of that sort. So I thought it was normal. So I just had my lots of work to do at home, and I had 2 sons. So I sort of skipped the medicine. Yeah.
Oh, so you're feeling, because you're feeling not having any symptoms, you were not very, thorough with taking the medicine.
Yeah,
believe.
I was
Oh,
feeling quite normal, doctor.
right, see. So are you on follow-up for your, you have heart attack and high blood pressure, are you on follow-up for in a government clinic or somewhere else? Are you on follow-up?
No, like I said, I was given the medicine,
Ah,
but I
so-
didn't take it regularly because I was completely feeling normal.
I see.
So,
Okay. So that is a small issue, actually. Now blood pressure, you might not see any side effects. We might not feel it initially, right? You can be going about doing your job, caring for your sons. I'm sure that's also, quite tedious
yeah,
thing to do, right,
yes,
at
yes.
home. So balancing your work and your stuff at home, you might not feel anything initially. However, all these things manifest, very silently. Sometimes, just when you do an investigation, you may find that you'll have an issue with your kidneys, because if you have poorly controlled blood pressure for a long time, it can affect your kidneys, as it has happened a bit now. It's not very serious at the moment, but it may progress. It's very good we control it at the, this grassroots stage.
I mean, with medicine, can we get it back to normal, doctor?
We can reduce, I told this protein in your urine, we
Yeah.
can sort of reduce it to a certain extent. You are on some medication for that as well when I referred your notes. But it's very important that we maintain long-term control, Ms. Kamala. Has anyone in your family also got this high blood pressure, heart attack, anything like that?
Actually, my mother had high blood pressure, and she also died of a stroke. She was on dialysis, and she died at around 60 years of age. Yeah, after stroke. So
I'm so sorry to hear that about your mother. It's a bit premature, isn't it? 60 years. So
Yeah.
that's the thing. So you may be having, just genetic tendencies to get this high blood pressure, and it's affected your mother's kidneys. It started to affect yours as well. So I think you must have been the carer for your mother, right?
Yes,
You're
yes.
right. So you've seen how hard it is. Was she on dialysis?
She was, yes.
She
She
cleaned her
suffered a
blood with
lot
machine.
before passing away.
Yeah, so I mean, you must have firsthand seen how hard it is. So it's very important that you maintain, have proper follow-up, because these medications we might change from time to time. We might be doing your your kidney functions. You check if there's more protein in your urine. We might be doing these scans of your heart, echoes later down the line. We may be looking at your eyes, because poorly controlled blood pressure can affect your eye as well. So in the long run, you can have issues with your vision. Sometimes you can have severe bleed in your eye as well, and that's not good. And more than that, even stroke. Of course, your mother has had a stroke as well, right? That's the thing. So if you have poorly controlled blood pressure, you might be also, unfortunately, we might never know what will happen. At some point of time, you might also be the victim of a stroke. So that's not very good, is it? Great. So apart from now, there's some problem with taking the drugs, I understand. Do you smoke? Do you consume any alcohol?
No, no, doctor, no.
Nothing of the sort. How about work-related stress?
It's like I'm very busy with work, and I don't have a help at home. So with my children's homework, housework, work at my workplace. So yeah, I'm very very busy.
Very busy.
Yeah. So
At home, do you have any domestic help?
no, I don't have.
At all. How about your husband?
He's also working, so we're both out in the morning, coming back home in the evening. All.
Great. So yeah, things are hard, but so we'll be prescribing you these drugs on your discharge this time. So I have to really, you have to take it to heart, I guess, that you have to take this medicine at the proper time, because some medicine it will be mostly at night, but others will be taken like twice a day. Have you been made aware of when to take this medicine and how to take it?
I think that the doctor told me. So
You've been told, right? Okay, so it's very important. And we'll be seeing how your progress is. And in fact, I understand it a busy lifestyle. Sometimes it's hard to, get the medicine, multiple pills at a time, right? So we'll be reviewing you after discharge. There are some new combinations in the market called polypills. So we mix 2 or 3 drugs together. And in the long run, it's shown that it's better. It will reduce your, like heart attacks or whatever in the future. And of course, it's easy because you will have to take just less medicine. So I think in your circumstance, that would be quite good for us to control your blood pressure and to prevent any things in the long run. Can I know your main concern at this point of time?
So thing is, doctor, I was not very okay with Western medicine. I was thinking, my idea was like, it'll damage the kidney if we take it in the long term. So concern is now with can this go back to normal, the condition I've got now?
Of course, Western medicine, as for our knowledge, I cannot advocate for other forms of medicine, because I'm not very, thorough with those. But as far as our Western medicine, the stuff that we give, what we've seen is, if you take the medicine for a longer time, it's more protective. And of course, the medicines that you are on, there's hardly any issue that will cause any issue for your kidney in the future. And it's good for your heart, it's good for your kidney, and it's even sometimes good for stroke as well. It like prevent, it won't 100% prevent, but your risk will be reduced. So yes, we can control your blood pressure. And as for your, I mentioned your heart was a tad bit weak, so it might improve over time with the medicine that we are giving. And if you do take it properly over the long run with good control, I think that will be good. Previously, apart from this, have you had any admissions to hospital with high blood pressure, like chest pain, nothing like that, right? So I think it's good if you could monitor your blood pressure at home too. You seem to be having a sound economic status, right?
Yeah.
Can you afford to get a good blood pressure controlling apparatus at
Yeah,
home?
yeah, I can
Great.
do that, doctor.
So on discharge, we'll be writing, prescribing you one as well.
Okay.
So you can take it. And at home, if you have any symptoms like a chest pain, dizziness, if you have something like difficulty to talk, it's hard for you to like walk, one side of the body is a bit heavy, right? That may be either something like a stroke or something like a heart attack, something like that. Or even if you're a bit dizzy, you can always check your blood pressure at home. We'll be teaching you, and we can teach your husband as well when he comes, right?
Okay,
That'll be helpful, right?
Yeah, definitely.
And we can do so. And so you can note it down on your clinic book. So when we come for a review, we can note how things are, how your blood pressure control is, what we need to change and stuff like that. Okay? Great. So now, have you had any do you have any side effects of the medicine that you've been prescribed so far?
No, doctor, even now I feel quite fine.
You feel
yeah.
fine, no? Not like you feel dizzy when you stand up?
No,
Nothing like
nothing.
that, right? And you can, walk fast, you don't have like shortness of breath, nothing like that?
No.
Okay. So the drugs that you have are actually quite safe. And I think it's quite important that you do take it properly on the long run, right? Yeah. So, of course, these diseases can't be cured, unfortunately, at this point of time, but you can control it on the long run, right? So if we do keep it in good control, so we'll be taking good care of you, we'll be monitoring you, and I believe it should be a shared care. If you also play a good part by taking the medicine and giving us proper feedback, we can adjust your medicine regime and give you really good service, and we could, try to reverse these and prevent any further bad complications. Okay?
Okay, doctor.
Right. So do you have any more clarifications that you need to ask from me at this time, Miss Kanti?
No, doctor, I think you explained everything. Just want things to get back to normal,
Yeah, it will in the long run. I will be reviewing you. So I'll be in the ward. If you do have any issues, you can let me know.
Sure.
Our staff is there, and I'll be meeting you in the clinic. For any further clarifications, we are out there to help you.
All right. Thank you so much.
Thank you so much.
Thank you, doctor.
See you.
You have some more time. You have about 2.5 minutes more.
So just for interest sake, you told me previously you have a bit of confidence with this, alternative forms of medicine, right? Are you on any medicine? Are you on any other alternative forms of medicine, like this Ayurvedic for your blood pressure control?
No, nothing.
Nothing of that
doctor,
sort, right? No, this Kasaya, Arishta, whatever you're not
No.
taking, right? Okay, that's good. Okay, but if you do take any other medicine which is not on our list in the future, just let us know, right?
Sure,
Because there may be interactions and side effects that we need to look into.
Yeah,
Okay.
sure, doctor.
Thank you.
Thank you, doctor.
Okay. Thank you, Mrs. Kanti. I'll give you a few minutes to gather your thoughts and then we will discuss. Changed. Okay, so how do you think that encounter went?
I think it went fine. The surrogate, the patient was good. She seemed to be. I think I identified the reason for poor compliance, and I think I educated her. And it seems to be. I thought that she perceived the knowledge well as well. She was not. She was. I think we were having a cordial relationship. It was not aggressive or anything. I think
Okay.
it was okay.
Okay, so why do you think her drug drug adherence was poor?
I think it's multifactorial because one, she was not having any adverse. She has had a heart attack before, but in the past few days, she mentioned, despite not taking the drug, she didn't have any adverse symptoms like chest pain or anything, and she was going about. So maybe the asymptomatic nature was contributory for it. And the next, of course, her lifestyle. She's quite occupied with her stuff at home. She's not having any support at home, and she's an employed female in administrative level. So she's having some stuff at work also. The lack of time, maybe busy schedule, and also maybe work-related stress also might be contributing.
Okay, so you told her about what are the problems that she could have if she doesn't control her blood pressure in future. What were her ideas about her current situation?
In the current situation, when I asked for her main concern, her concern was after I mentioned about this kidney problem and this small issue with her echo. I think her main concern was reversibility, whether she could reverse the changes that has occurred. And I think currently she was having a bit of poor insight regarding her disease.
Okay.
That had led to this poor pharmacoadherence. So I think the insight was a bit poor, but concerns-wise, it was to reverse this kidney issue, the renal adverse effects, and the cardiac.
Wasn't she very concerned about her mother's problem, that it could happen to her also, that she also might end up on dialysis?
I think she was a bit concerned too.
She had a concern.
She had, but I don't think it was of adequate gravity.
Okay.
Because she was the primary carer for her and seeing all
Okay.
what she'd been through.
So now you gave some advice about controlling of blood pressure, and it felt to me like it was mainly the pharmacological control of blood pressure you were talking about. Should you have talked a little bit about the non-pharmacological measures as well?
Yes, madam. I think I missed it on my part.
What should you have told her?
She was not having any, she was not smoking or having any alcohol. So I would have advised her on exercise, having aerobic exercise at least 150, 130 minutes per week. And then, if necessary, resistance training. And of course, if she's under work stress, I would have advised her on any stress relief methods. And she was having any stress, I could have referred her, if necessary, for any psychotherapy for her stress. I could have done that on my part.
What about diet?
I could have done that too.
What would you have told her about diet?
Salt, I could not ask on the salt intake. So advise her on a low salt diet.
So essentially, it should have been a more holistic approach, isn't it? It should have been a lifestyle modification in addition to the pharmacotherapy. Yes?
Yes.
Yes. And the problems that she had about non-adherence, you'd have to try to break that cycle so that she will continue to come for follow-up, isn't it?
Yeah.
You were talking about polypill. Is the polypill available for purchase in this
No,
country?
but I've seen, I think, from your faculty, madam, they've done some from Calanie, isn't it?
It is not available
Not
for
available, but
purchase.
it's not purchased.
Still
But research stage.
NMRA has not still approved
Approved
any
it.
polypills. What we have are the two drug combinations, isn't it?
Yes.
So you can't ask her to buy things that are not available in the market. But of course, what the point you made about improving adherence with polypills, it's very true. People like this lady would benefit with with polypills, but it's not available in the market. So what you have to tell her should be practical. You could probably put her on 2 drug combinations that are already available in the market, which will improve adherence. Okay, so do you think with the advice that you gave her, particularly about monitoring her blood pressure at home, is that what you'd want her to do, monitoring of the blood pressure at home, only if she feels unwell to check the blood pressure, or how would you ask her to monitor her blood pressure at
If
home?
she have any symptoms, I would advise and also, madam, maybe some random measurements either before she goes to bed at night, and I would advise on that as well because she's having a poorly controlled blood pressure.
Wouldn't it be better to give her a structured way of checking her blood pressure, maybe once or twice a week, on waking up, on going to bed, and writing it down?
Yeah,
Isn't
that,
it?
That would
Yeah?
be better, madam.
Okay. All right. Thank you very much.
Thank you, madam.
So, how do you all feel that encounter went? I thought he did reasonably well, but I'm going to take you through what is actually expected of candidates when we are going through this, this particular communication skills station. A lot of candidates find this a little bit more difficult than the observed history taking. So this is what the examiner was looking for. This was a counseling session to improve adherence to antihypertensive therapy. And the need for the candidate, what we wanted the candidate to do was to explain the need for better control of blood pressure, talk about the organ complications and the prognosis, and the need for adherence with medicines and diet, motivate to adopt a healthy lifestyle. So our candidate talked quite a bit about better control of blood pressure, talked about organ complications, talked about prognosis, talked about adherence to medications, but was a little bit unsure about healthy lifestyle, diet, exercise, etc. I think it slipped his mind a little bit. So he obtained the social history regarding the hypertension and the ischemic heart disease management. He got all the reasons for poor compliance, and he gave the reasons for good blood pressure control, why it should be controlled. He talked about target organ damage. He talked something about the natural history of complications if the blood pressure is not controlled, and he gave a management plan. So all that was okay. He was sensitive and firm to the surrogate's emotional reaction. She was upset about all the problems that she was supposed to have, and she encouraged the surrogate to understand the problem and change her behavior. Elicited the ideas, the concerns, and the expectations, and gave a management plan, although the management plan was a little bit lacking from the lifestyle part. So this is generally the kind of examiner document that we have for this kind of an encounter. It's quite explicit and very explanatory, and we expect all these things to be covered by the candidate. So what do we test in a CES station? We look to see whether the candidate can identify the challenge and then develop a plan for the encounter. Ask yourself, what is the task? What must I find out from the surrogate? What exactly must I communicate? And are there other areas that I must cover during the encounter? And then we look to see how well the candidate conducts the encounter. Establishing a rapport, very important. I thought our candidate established a reasonably good rapport. Exploring the patient's understanding. You have to question the patient. How much do you know? Know the background of the patient, find out how much do they know. Then provide information clearly, appropriately, and adequately. That is the answering skills of the candidate. Check for understanding. So you have to listen to what is happening, listen to what the patient is saying, and then also question as well. Clarify questions and doubt, and then arrange the follow-up plan and actions. Here there was not a lot of negotiation to do because the surrogate was already very motivated to change her behavior. So, does the candidate display empathy and emotional intelligence, understand what is happening in the encounter? We are looking at that. Is the candidate professionally competent, conducts the interview in a courteous manner, and then talks to the examiner to clarify the doubts and unclear areas about what was observed, specifically check for the background knowledge on the task, and specifically check for how much he or she understands the patient's perspective and comprehension of the information that was given. So, in this encounter, although we are mainly checking communication skills, we are also checking some degree of your medical knowledge as well. As was very clear in this encounter, we are checking your medical knowledge as well, but this is predominantly a communication station. So you had to have your background knowledge about the natural history of the complications of diabetes, of hypertension, and how to manage hypertension in a primary care setting. So this is the breakdown of the marks. The station assesses transmission of information. The vast majority of the marks is given to exploring of present understanding, 40%. Introduction and explanation, 20%. So putting the patient at ease, explaining what he or she hopes to do, the non-verbal cues, pauses, spacing of the interview, all of that, 20%. Exploring the present understanding, that is 40%. That takes a lot of marks. Explaining in simple language, avoiding medical jargon, inadequate explanations and medical jargon, that has to be avoided, and checking for understanding. So it's always very good to every once in a while ask the surrogate, do you understand what we are talking about? Is there anything you need to discuss? Explores and addresses the patient's concerns, 10. Professional attitude and empathy, 10. Demonstrates adequate knowledge of the issues related to the encounter, 10. And good insight into the success or failure, 10 again. Marking scheme, each of those categories will be marked on this marking scheme. I think you're familiar with this. And common mistakes. I need to spend a little bit of time on this. Not reading the scenario is probably one of the commonest mistakes that candidates do. You have to read the scenario very carefully. Spend that 5 minutes that you have outside the room very wisely and make a plan of this is how I'm going to approach this problem. Making a differential diagnosis, identifying the problem, this is how I'm going to approach it, these are the issues that are there. Identify the whole purpose of the encounter while you're waiting outside. Don't use jargon. Try to show some empathy and emotion. Even if you don't feel it, you have to act a little bit if you must. Listen to the patient, listen to the surrogate. You have to listen. This is not just you talking. You have to listen to the surrogate because you have to get the information from the surrogate first. And you saw how much of marks that are being given for you being able to elicit the information also. Pace the interview well. Use the full 14 minutes to your best advantage. Use the full 14 minutes. Pace it well. You will get a warning at 2 minutes also. And not being mindful of the time. Now, I had to be mindful of the time now because I have been given the bell and I have to finish this. So these are the common mistakes that candidates make. I think overall, our candidate will pass this station. Thank you.
Thank you very much, Madam. For the next session on observed history taking, I kindly invite Professor Uday Ranapanava, Professor in Medicine, Faculty of Medicine, University of Peradeniya, as the examiner, Dr. Vidarsha Senadira, Medical Registrar from National Hospital Galle as the candidate, and Ms. Tilini as the patient surrogate.
Right. Very good morning. Let's move to the second component of this important exam. And so the second component is observe history taking. So without taking much time, we'll directly move to the scenario.
Good morning.
morning,
I'm Dr. Vidarsha. I'm the doctor who will be taking care of you today. Can I know your good name?
I'm Sarani, doctor.
Sarani?
Yes.
So Sarani, how old are you?
I'm 27 years old, doctor.
Sarani, can I know what brought you here today?
So, doctor, I've been having this chest pain, and along with that, I've been suffering with this bit of breathlessness as well. So that was there for the last 1 week, doctor.
Can you tell me more about the chest pain?
So, doctor, it started, as I said, just 1 week back, and mainly around the center area, and I felt it's like moving to the left side as well, doctor.
So you move to the left side.
Yes, doctor.
So did it start all of a sudden, or is it there all the time? Does
No,
it come
doctor.
and go?
It started suddenly, doctor. Yes.
So how long does it last at a time?
For a few minutes, doctor, like I get it a bit, and it goes away, but it comes again, doctor.
So what is it like? Is it like tightening, like somebody's like crushing your chest, or
I felt it like it was a sharp pain, doctor.
okay?
Yes.
Can you point it to one location, like with your?
Can say around the chest, main central area, and then move into the left side, doctor.
So when you take a deep breath, like does the pain get worse all of a sudden, like it's pricking?
Yes, doctor, bit, yes.
Like that?
Yeah, doctor.
Okay. So you mentioned it went to the left side. So did it go along your arm, or did it go to your neck region?
No, doctor, it didn't go like that, just moving to the left side more. That's it, doctor.
So did you also like get other symptoms, like was there any sweating, or did you feel like very nauseated, like you felt like vomiting?
No, doctor, no, I didn't feel like that.
Did you feel like it was going to the back of your chest by any chance?
No, doctor, no, just front chest, yes.
So when you move, does it get worse?
Yes, doctor, yes.
Okay. So when you move forward, does it get worse or is it better?
No, doctor, it gets worse. So when I move front, like bend myself into front, I get the pain, doctor.
Okay. So what makes it worse, and what settles it from your experience?
So in the last week, doctor, so I've noticed that whenever I'm doing, even the smallest activities, I felt this pain. But I didn't try anything much, doctor, to check whether it settles, but it goes away.
So when you rest, does it go away, or with the posture, does it go away?
When I rest, yes. Yeah, doctor.
So how bad is this? Like in a scale of 1 to 10, how would you say? Like 1 being the least and 10 being the worst pain you ever had?
Around 5 to 6, doctor.
5 to 6. Okay. So you also mentioned that you have some trouble breathing.
Yeah, doctor.
So do you also have a cough?
No, doctor, no.
So have you ever coughed up blood or anything like that?
No, doctor, no.
So is this like breathlessness there only when the chest pain is there, or when does that come?
So, doctor, firstly, it was the chest pain, and then only I got the breathlessness also.
Okay. So have you been feeling very lethargic, as in like you get tired really easy, you don't want to do enough work, like you get like...
So, yes, doctor, I noticed like that. So, whenever I'm doing even the smallest work, like I've been very active before, but now I can't do like that. It's hard to breathe and I get the difficulty.
Okay. So have you noticed any bleeding recently, like your menstruation? Like, is it worse than...
No, doctor, no, didn't notice like that.
So any other bleeding, like when you open bowel, like when you pass stool, is there blood with it?
No, doctor, no.
Any problem in your family with related to blood? Like, having blood transfusion, needing to take iron or like something like that?
No, doctor, no, nobody.
Okay. Can I know if there's any significant thing in your family, like heart problems, like getting heart attacks very early in life or having like a sudden death?
So yes, doctor. Recently, I lost my brother. That was just 1 month away, doctor.
I'm very sorry to hear that. How old is your brother at that time?
He was my twin brother. He was just 27 as me, and he also got this heart attack, doctor, and he passed away.
Okay. Can I? Is it okay if I ask a bit more about it right now?
Okay, doctor, it's fine.
So, uh, what was your brother doing at that time? Did it come all of a sudden, or did it like did he also have a chest pain, or?
So he was doing cycling, doctor. So that's when he got the heart attack.
Okay. Was it confirmed that it was a heart attack, or were you told that his heart was a little bigger than normal?
Didn't know about anything like that, doctor, but during his, after confirming with his postmortem, only they confirmed that he had a heart attack.
Okay. So, anybody else in your family who had like a sudden death like this?
Nobody else, doctor, just my brother.
So, what about like diabetes, cholesterol, and high pressure?
My mother, she has diabetes and hypertension, doctor, but father is all right.
So, did she get these diabetes and hypertension like relatively young or towards the?
I think when she was 40 years old, doctor. Now she is 62.
Okay. Before you had this chest pain, did you have a fever or something like like a flu?
No, doctor, no. I was okay.
So, have you noticed there's some swelling in your legs?
No, doctor, no swellings in my leg.
Did you have like a long travel, like maybe in a airplane or in a bus?
Yes, doctor, but this was 2 years back. I had to travel to Australia to see one of my relatives, but 2 years back, doctor.
Okay. So, have you noticed like you're getting on and off fevers and like you're getting a rash in your face when you go to the sun, joint pains?
No,
things like that?
doctor, no, no.
There's nothing of that sort.
No, doctor, nothing like that.
But are you on any other medication, any other diseases that you have?
No, doctor, no, nothing at the moment.
Any surgeries that you've gone through?
No, doctor.
Allergies that I should know about?
No, doctor, no specific one.
So you mentioned about your brother's unfortunate event.
Yes,
So you must be like it must have been a big blow.
Yeah, doctor.
How are you coping with it?
I'm okay, doctor, but after my brother's funeral, like I couldn't even go out much. So all I was doing was I was at home in my room. I was isolated. I couldn't face people much. I didn't want to talk with others. So even work, doctor, I had it work from home for the last 4 weeks now. That is how I've been living, doctor. It was terrible because I was very close with him.
Yes. Who's there to support you at home these days?
So, doctor, my parents are there. So I live with them, doctor.
Yeah, I can only imagine. These days you mentioned that it's a little harder to do things and like you've been very upset and
Yes, doctor.
feeling very low.
Yeah,
Can you do your day-to-day activities or do you need some help for that?
Like I can manage, doctor. Day-to-day activities I can manage, but as I said, like I've noticed that I'm getting this pain and short of breath time to time when I'm working, when I'm doing even little things. So that is there, doctor.
So is it when you think about these symptoms, is it worse or do you get really anxious and do you feel like you'll also have the same issue?
So, doctor, I'm worried about it, doctor, because I just lost my brother and I'm also having these chest pains and short of breath. I'm also thinking if this can be that this is the same thing, doctor.
That is a valid concern at this point because it was a very young death
Yeah, doctor.
and it was not very well explained. So So what is your biggest concern at this point?
So, doctor, I'm really worried now. My brother also died. So, am I also going to get a heart attack at this rate after, having this chest pain and everything? Am I going to end up like that?
We will get to the bottom of that and we will find answers to your questions. And I will definitely get the help you need. And if there's anything of that sort, we will try to correct it and prevent such a thing. So your current idea is also like around this point, right? Like,
Yes,
your
doctor.
brother's death and how it's going to affect you in the future and all.
Yeah,
So
doctor.
what is your expectation?
So, doctor, I would like to know if I should get admitted or if there's any treatment that I should follow.
Okay. So have you got any testing done before?
My doctor, he did some ECGs, doctor, but he said those were normal.
What about any blood work?
Yeah, doctor. Yeah, but he said that was negative or something.
Do you smoke?
No, doctor, I don't.
Use alcohol?
No, doctor.
What about other drugs?
No, doctor, nothing like that.
Nothing like that. Okay. So you mentioned that you have support at home. Is there anything else that you think I should know?
No, doctor, that's pretty much it.
Any other clarifications that you had to ask me?
So, doctor, the main question was if this is something like my brother had, should I do something, any treatments that is there for this?
Okay, so far from what I've discussed with you, definitely I'll be ruling out causes of like anything that's wrong with your heart. So I'll arrange some investigations like testing, like the blood tests. We can do echo in your heart. Echo means like a scan in your heart.
Okay.
So we can see if it's like the normal way it's supposed to be, or
Okay.
if it's a little different. And then we can go ahead with that, and I'll also like to take an X-ray because you mentioned it's just in one point, and maybe we can find if there's something wrong with your lungs. In addition to that, have you been having any sensation that your heart is beating so fast?
Yeah, doctor, yeah.
So usually you don't feel it, right?
No, doctor, no.
So it comes with these like chest pains, is that so?
Yes, doctor, yes.
Okay. Do you feel faintish with it?
Dizziness, bit of dizziness, yes, doctor, but occasionally, not all the time.
So it started like in 1 week, right? You haven't
Yeah,
been
doctor.
having any symptoms previously.
No, doctor, no. During this 1 week, yeah.
Okay, we'll once again go through the ECG, and if I can't find anything, there's like more testing to be done. There's an ECG, like a small machine, you wear it like a school bag, and so you can keep it for like 24 to 48 hours.
Okay.
So if we don't catch anything in the ECG, there is a chance that we might find it over the 1 to 2 days that you'll be wearing it. So we can arrange all that and make sure make sure it's something wrong with the heart or not.
Okay.
So I also noticed that you're having trouble adjusting to the new change.
Yes, doctor.
So I feel like you are anxious as well. So you've been right now it might be a normal grief reaction. So if it lasts for a long time, you might need some help with your emotions as well. So we'll be we are ready to address that as well.
Okay, doctor, thank you.
So right now, do you have any sensation, like any feeling like to maybe harm yourself?
No, not like that, doctor.
Okay.
But I'm okay, but I'm also worried about it, doctor.
So we'll be taking care of your anxiety as well.
Okay, doctor. Thank you.
I'll be around, and if you have any more concerns, you can ask me.
All right, doctor. Thank you.
Thank you.
Right. How do you feel about this encounter?
All right.
Sorry?
about this encounter. So after talking with her, I have identified several problems.
Yeah, how do you feel? How about the patient or a surrogate?
She gave a very clear history. She answered the questions directly, and she gave me a overview initially about what's troubling her. The surrogate gave a good history, I think.
So, were you able to come to a diagnosis,
I have several differential diagnoses.
right? So, what are the possible differential diagnoses?
So the first one I would consider a cardiac cause, mainly because of the very significant family history. Since she's having symptoms of chest pain, palpitations, and shortness of breath, so I would, though this is unlikely to be a myocardial infarction at this point of time, so it could be a cardiomyopathy, which is manifesting as palpitations and shortness of breath. So it could be that. But then because of this very, she didn't, my second, I would like to exclude an event of a pericarditis or pulmonary embolism, but it's a little lower down in the list because she didn't have a clear history of a precipitating factor. My other differential diagnosis is anxiety.
Anxiety, right. Okay, now you said most probably it is a acute coronary syndrome or a cardiac cause.
I'd like to exclude it, first of all, because that would be the cause that would cause a mortality in this patient.
Because of the family history.
Because of the family history.
Right, you said pulmonary embolism is unlikely. Why is that?
Unlikely as in, she mentioned it's
No,
not.
you said no precipitating factor. Can people get pulmonary embolism without precipitating factors?
They can.
Sorry?
They can if there are. If she's having a condition which is predisposed into clots and so forth.
I heard you ask about some rash or joint pain. Why did you ask that question?
Because if she's having a connective tissue disorder,
You thought about pericardial.
and thromboembolism.
Thromboembolism.
Because they can get arterial and venous thrombosis, which can lead to pulmonary embolism, and as well as pericarditis and
Okay.
myocarditis.
So were you able to explain the patient possibilities, the probable differential diagnosis?
I mentioned the testing that needs to be done, and we'll be looking at the
No,
heart.
but did you explain the patient or a surrogate about the possibilities, Now she is worrying, not about the reports, she is worrying about the condition, what the disease she is having.
I didn't mention the disease exactly.
So don't you think you have to tell, these are the possibilities and this is how we are going to sort out the problem properly by doing the investigation. And you mentioned about the echocardiogram, and you mentioned about the, I think, possible Holter monitoring. And don't you want to do to exclude the test to exclude pulmonary embolism?
Yes, sir. I would want to do that. That's why I mentioned about the blood tests, and if it is there, to go ahead, can do. So, and I also mentioned the chest X-ray about that. So I didn't mention about a compressive ultrasound scan in the legs or a CT pulmonary angiogram at that point. I didn't go into
You
details.
didn't thought about pulmonary embolism as a main diagnosis.
Actually, I didn't explain it because it would need like a technical jargon and all that.
Okay. Now, her twin brother got a heart attack. Now, if this is a possibility of pulmonary embolism, can you explain those, the arterial thrombosis and venous thrombosis by one pathology?
Yes, sir. So there are several conditions that can cause arterial and venous thrombosis. For example, so connective tissue disorders are one thing. So if it's APLS or Behçet's, but in simple things like, not simple, it's like polycythemia itself can cause it. And then if she, that's why I asked about any anemias, sickle cell anemias can cause.
So, what are the thrombopaedic condition? The congenital inherited thrombopaedic condition which can give rise to arterial and venous thrombosis.
Hyperhomocystinemia.
What? Any protein deficiencies? Protein C, protein V.
Protein C and S deficiencies.
Right, now patient was repeatedly telling her ECGs and troponins were negative, no?
Yes, sir.
So then, that time you could have think about this is very unlikely to be the major cardiac event, isn't it?
Yes, sir. It would be unlikely. I mentioned it first because that would cause the highest mortality, and I would want to
Okay,
explain.
anyway, right. Thank you very much, right?
Thank you, sir.
Right, anyway, I think, how do you feel about this encounter, Right, so according to our prospectus, the observed history taking and communication skill component has two the station, basically observed history taking, which was done by Professor Shamila, and other one observed history taking done by me, and the communication station done by Professor Shamila. So the both station, the one station lasting only for 20 minutes, and the marks will be given by two independent examiners. So why this station exists? So the why OHT exists? It assesses ability to take a focused, clinically relevant history during this 20-minute encounter, and it evaluates communication skills, empathy, and rapport building. It tests the diagnostic reasoning through history alone, so without any investigation or without examining the patient. And it demonstrates ability to provide the coherent summary and differential diagnosis. So during the encounter, unfortunately our candidate didn't summarize the thing to the patient. So it is a good practice you to summarize, do some discussion and give the summary, and continue this discussion, give the summary. Like that, that's a good practice. And a station format, usually 5 minutes for the candidate to read the scenario, usually outside the discussion room. And then 40 minutes to take history from the patient, 1 minute to organize your thoughts in the real exam, and 5 minutes for the discussion, your findings with the examiners. In this station, no physical examination is required. Examiners assess both content and communication skill of the candidate. Core skill required to pass this exam. The examiners look for these things in the candidate, to how candidate establish the rapport quickly with the patient, taking the relevant and logical history, exploring symptoms thoroughly, assess impact on life and functional state of the patient, identify the red flags in the scenario, explaining reasoning clearly in the discussion, structuring diagnosis, differential diagnosis and management plan. The structure of the excellent history, it is a focused, efficient approach. Our candidate, she took fairly good history, but I noted she took a lot of time to take the history. That is one of the things that you have to correct. So you try to target finishing taking history by 10 minutes at least, and leave 5 minutes for you to explain, summarize, discussion and everything, right? Otherwise, there won't be enough time to explain and give your feedback to the patient. So during the opening of the discussion, introduce yourself, she did well. Confirm patient identity, she did it. And she started with the open-ended question, that's a good thing. So always try to start with the open-ended question. And so allow patient to talk, that's the best thing. Allow patient to talk while, and then you can start asking the close-ended question. And so always try to explore the symptoms, the timeline, how long, what happened over this patient history is for 1 week time. So try to explain over the 1 week time what happened. So I think then you will understand what sort of shortness of breathing and chest pain in this patient. And then the targeted systemic inquiry, functional impact because of the illness, and relevant past medical, drug and social issues. You took it, you have addressed that area. And patient concerns, ideas, expectations, we try to address. So I think that is not adequate. And communication essentials, how to demonstrate professionalism. You have to warm, respectful, and calm tone. I think you are good in that sense. And allow the patient to speak, avoid interrupting too early. I feel that if you allow little more her to talk, that's better. But you didn't disturb her too much. But she's very good, the story. She's a good surrogate. Use open question first and focus question later. Respond to emotional cues. Now she mentioned about the death of her son, the brother, but you didn't have good emotional cues. So so I'm very sorry. The acting, that part was missing during the discussion. So respond to emotional cues, and then the check understanding and summarize periodically. That is very important. Check understanding. So ask from the patient, the surrogate, did you understand what I said? Then you can move forward, right? And avoid jargons unless explained. You mentioned about echocardiogram, but you explain it. That's correct. So we are doing don't bother about this medical term. We are doing the test called echocardiogram. It's a scanning of your heart. Like that you explain. Then it is not a jargon. So the examiner's questions. At the end of this 50 minutes, expect to be asked. This question will be expect to ask. What is the most likely diagnosis in observed history taking, and what features support this diagnosis? What else might this be? What further history, examination, investigation are needed? How would you manage this patient? So we couldn't discuss that part, unfortunately. What complication are you worried about? Like that we are having some set question to be asked at the end of the discussion. So square endowments, mainly how you are marked, clinical communication skill will be assessed, history taking skills assessed, clinical judgment, reasoning, organization and summarization, professionalism. So most of the skills are assessed during this history taking station. The common mistake we do, jumping into close question too early, focusing on irrelevant details, right? So when you are taking history, don't go to unnecessary thing, because you have limited time. So always read the history as Professor Shamila said. Carefully read this story or what is given to you, and underline what are the important points in. Don't miss these red flags. So not exploring patient concerns, but you explain. So tips to success, use 4-minute template and practice time stories. Listening actively, patient often give the diagnosis. Start broadly and then narrow down the story. Signpost your approach to the examiners. Stay calm and think aloud clearly during the discussion. So key take home, focus on relevance, structure and clarity, demonstrate empathy, professional communication, present a clear diagnosis and differential diagnosis to the examiners, practice time history regularly. The station rewards clarity, confidence and clinical reasoning. Thank you very much.
Thank you very much, sir. And I take this opportunity to thank the 2 registrars who volunteered and helped with the session as well. May I kindly invite Professor Shamila De Silva also back on the stage to hand over the certificates of appreciation, following which we will have a group photograph along with the 2 registrars.